I missed, Samantha, a little bit of the end of your talk just because people were gathering in the Zoom room. And so if I could just ask you, so the overall carrier frequency that you cited was around 1 in 250 or something like that from the NOMAD database. And so then the allele frequency would be somewhere around 1 in 125 or something like that if we round off. And so then the square of that roughly is going to be the affected frequency. So that would be around 1 in 10,000 or something like that. Is that correct?
So the allele frequency would be about 1 in 500, and then you times that by 2, and that gives you your carrier frequency of about 1 in 250. That is adjusted again to include the 355L variant. So if we didn't include that, the carrier frequency is about 1 in 280.
Uh-huh. Okay. All right. So I did my math wrong in terms of the multiplication or division by 2. But yeah. Okay. Thank you very much for that. So in any case, we do have a number of questions actually on the list that came through Google Docs, and I know actually that Tim is not going to be with us for the whole time, Tim Bernard, and so perhaps we can start with him so that we can at least get some of the questions addressed to him. And if some of these questions, Tim, are questions that you've already dealt with in the chat, let me know, and then we can move on. But I think that this is an FAQ, a frequently asked question, and that is a question: would you give preventively anti-TNF to an asymptomatic sibling of a patient with strokes, given that they might in the future have a stroke that could be devastating?
Boy, that's a tough question for me. I would probably ask my rheumatology friends what to do with an asymptomatic carrier or an affected individual. And so that's how I would handle that.
Uh-huh. You would consult someone else. Okay.
That's right.
But, you know, we happen to be in a circumstance in which you could consult someone else. And,
perfect.
Do you want to call on your consultant, or should I?
If you could, that'd be great, Dan. Thank you.
All right. Well, Mandy, why don't you give us your point of view on this? Of course, it's just one person's point of view, but let's hear it.
Thank you. So my point of view, for what it's worth here, is that we had the unfortunate experience in our cohort of having an unaffected sibling opt out of treatment for a while. And then he went on at the age of 21 to have a stroke. So the risk is definitely there. And I look at it that he was fortunate that it was a stroke that he bounced right back from and doesn't have really many residual deficits. But, you know, talk about changing one's life trajectory in a minute, just a second. The stroke happening, you know, at the wrong place at the wrong time could do that. And we've seen those effects within our cohort of the lesser fortunate patient. So I look at it as if I can do anything to prevent this from happening in someone, I'm willing to take the risk almost 100% of the time to put them on treatment, even if they're asymptomatic or minimal symptoms.
All right. Well, Mandy, thank you very much. Pui, would you want to comment at all on this? Since certainly you've thought a lot about genotype, phenotype correlations, especially in the last year or so.
I think I mostly agree with Mandy's approach. I think if the patient's really on the vascular spectrum of things, or having a family member or sort of previous cases with the same genotype, that certainly will sway my decision. The only caveat is if the patient has profound immune deficiency or sort of neutropenia, where there's a high risk for infection, and then we piled on a TNF inhibitor, that certainly make things worse. But that's unlikely we're discussing in terms of a asymptomatic scenario. So that's, but I think, you know, it's, as I tell my patients, right, with kids with a swollen finger for a few months, we put them on TNF inhibitor. So the risk versus benefit is certainly on the side of treating and preventing a stroke.
Yeah, and certainly putting things in the perspective of other agents that one could consider in these kinds of circumstances before the recognition of TNF inhibitors, glucocorticoids, for example, have a much broader spectrum of side effects than TNF inhibitors would. But certainly this is a question that comes up a lot, and I certainly thank the questioner for asking that question. Is Tim still with us? I don't see him on my checkerboard square anymore. Okay, he apparently was kidnapped by space aliens, and so in that case, we will move on to questions directed to other of the culprits here. And so I see that someone asked a question to Ed Cowan with regard to how common is LCV, which I take it would be leukocytoclastic vasculitis, in DADA2. And is IgA deposition found in those circumstances? Ed, do you have any thoughts about that?
Yeah, so when I looked through the literature, it was primarily mentioned in sort of the reviews. And so I didn't see a lot of specifics. And so I can't, to the question about, immunoglobulin specificity, I don't know the answer to that. I don't recall seeing a case here in our cohort. Maybe you or Mandy have a better memory than I do about that. But primarily I saw that just in sort of the anecdotal, sort of more general descriptions.
Okay, well, thank you, Ed. Mandy, do you have any thoughts with regard to leukocytoclastic vasculitis in the cohort of NIH patients?
I don't recall that buzz term has been used in our patients. In fact, it took us quite a while to within our biopsies that we performed to really even nail one that did have active vasculitis in it. It was more of a vasculopathy picture of a lot of the time. And some came to us with biopsies that showed more consistent with PAN, but I'm assuming those probably had some vasculitis on them, but not leukocytoclastic, as I recall.
All right, so Ed, you're not off the hook yet. So now we have a master's question. I think this it definitely falls into the category of extra credit. And so the interrogator wants to know if you can give pointers on how to distinguish DADA2 from SAVI at a dermatologic point of view.
Yeah, so sort of the easiest terms from a clinical phenotype, SAVI, I think of as a very aggressive early onset vasculopathy. And so, most of our NIH patients haven't had a very severe acral phenotype. We've seen mostly PAN, sort of nodular lesions, and the livido presentation, but we really haven't seen a lot of the patients with the aggressive acral, violaceous, purpura and actual skin necrosis that can be seen with SAVI. So certainly, I know it can occur in DADA2. And in the original reports, I know there were some pictures of that. But that early, very aggressive onset is pretty distinct for SAVI, and we don't see that so much in DADA2.
And just for those who are not aficionados, SAVI stands for sting-associated vasculopathy with onset in infancy. So SAVI is caused by mutations in STING, which is a signaling molecule, a sensor for double-stranded DNA intracellularly, and the mutations are gain of function and lead to an interferonopathy. But because it's expressed in endothelial cells, it does lead to a vasculopathy. And so, as Ed says, it's a very early onset disease. The patients who have it, it's heartbreaking to see them because they're losing digits when they're young children. Their parents obviously are, before the discovery of SAVI, were beside themselves, wanting to know what to do, and we were just as helpless as anyone else in terms of dealing with that until Raffaella discovered the mutations in STING in those patients. So in any case, let us move on to another question. Let's see here. Since Tim is not here anymore, I think that I will go on to a question for Troy. Can you test T follicular helper cell function directly by peripheral blood, not from B cell function?
So it's challenging because because of course the T follicular helper cells don't live in the blood most of the time. They live in the lymph nodes, which is where the majority of them reside. So if you do flow phenotyping with looking specifically at T cells, you know, in most normal individuals, you only see a small percentage. So, you know, maybe 1% of the CD4 T cells will be T follicular helper cells. So there are markers for them. You can see them. You can find them, but but you need to. When you do flow, you need to look at a lot of cells to be able to detect enough of them to really get statistically significant data on them. So it's challenging. I think in the paper that Marco published, they were looking really just at I think bulk PBMCs and or bulk peripheral blood T cells and CD40 ligand induction, which is easy to do. So there are clinical labs that look at CD40 ligand induction. It's easy to do in a research lab. But, you know, I think while Marco's paper is really enticing and suggests, you know, something really interesting there, I think that we don't know all the details yet on that and whether that is something that is going to be universal among all patients, whether that's would be useful as a diagnostic test. At this point, I think it's still very much research. And I think, you know, the more straightforward thing where there's more data is looking at the decreased memory B cells and decreased class switch B cells, which you can do by B cell phenotyping and is, you know, clinically available in many, many places.
Mm-hmm. Yeah, I think that's a very good answer to that question. Okay, so now I'm going to move the Klieg light to Mandy. And there's a question for her. What does the use of methotrexate, I guess it's, this is a little bit, the sentence is a little bit garbled here, but I think the question is, how often do you use methotrexate in patients on monoclonal anti-TNF agents, or under what circumstances would you use methotrexate?
Well, historically, we didn't. And I must say, especially for the young children, we tend to start them off. In fact, most people, we tend to start them off on etanercept, at which, because it's a fusion protein, we don't need to use methotrexate in those patients. So they're not on it. But for the patients who we switched to adalimumab, we found that there were a couple patients who over time, we seemed to have some waning efficacy. And we were kind of baffled because they had been doing so well. And indeed, when we tested anti-adalimumab antibodies, they were present. So we, in order to ward those off, kind of like one might do sometimes when in a rheumatoid arthritis patient, we have started putting them on methotrexate to try to ward off these anti-drug antibodies, because although there is a number of anti-TNF agents available now, if one's looking at being on it for a prolonged period of time, you really just don't want to burn through them if you don't have to.
All right, so now a follow-up question from someone else, but I guess it was a tag team approach. And so now the question is, do you ever, or how often, or under what circumstances would you use anakinra in combination with a TNF inhibitor?
So again, historically, patients came to us at the beginning who were on anakinra. And yes, it could lessen their inflammatory burden, but they were still experiencing strokes on top of it. I can think of a couple in particular who had that happen. But we have found that although anti-TNF agents are really great at reducing inflammatory burden, there are some patients who can really amp up the disease for unknown reasons at certain points in time, and they'll get like breakthrough fevers or breakthrough rash. And we have found in those patients that adding an adjunctive anakinra for a period, not indefinite period of time, that can really help to bring them back to a homeostasis. And then we're able to back off of that once they get quieted down again.
Now, Mandy, isn't it the case, I've read or heard tell that the infection rate associated with a TNF inhibitor itself is not too high, and similarly for an IL-1 inhibitor, not too high, but if you put the two together, then you compound the situation and get a much higher rate of infection. Doesn't that worry you?
Wow, what a wonderful question. And what I can say to that is that, yes, indeed, back in the literature, you can see that in rheumatoid arthritis, they did try to combine these therapies historically, and they did see an increased rate of infection. However, my primary focus is in the field of autoinflammatory diseases. And we have found that in the autoinflammatory, not autoimmune diseases, that we have been able to, not that we like to do it, but we have been able to do combination therapy in some of our disease refractory patients in order to best keep their disease quieted. So again, the utilization of anakinra would be for a PRN period of time, and IL-1 agents, anti-IL-1 agents have such a good safety profile that we have not yet, knock on wood, not yet had any of those complications. But it's definitely something to consider, especially if you have one of the more immunodeficient DADA2 patients.
Okay, so two more questions and then I'll let you off the hook. Even though there's more there for you, but I'm going to move on to others after these two questions, if you get them right. So the first question is, JAK inhibitors in DADA2, have you ever used them? Yes or no?
No.
Did we get that right? No.
No, I have not. But yes, I have considered it. Again, much like with the anakinra, I would definitely consider it for some of the patients who are having some refractory disease. Although at this point in time, I would not replace anti-TNF with a JAK inhibitor.
Okay, and then the final question, someone is asking if there's any correlation or if it's been looked at yet between IL-23 levels and the interferon score.
No, not directly. This is really kind of more breaking news as far as the IL-23 went. So we are just going to start to roll out testing and doing some more investigation. For instance, in a patient who's having ongoing vasculopathy problems or cutaneous ulcers, if we can't test both the IL-23 level and do gene expression of the interferon pathway at the same time to see if we've got correlative results there.
Okay, well, great. Thank you so much, Mandy. So now I'm going to move on to Pui. Actually, this question is prefaced by an accolade. Awesome talk, Pui. And now the question. Could you please comment on disease activity and treatment effect on ADA2 levels? In other words, does disease activity correlate with ADA2 levels, say longitudinally, and do treatments have an effect on ADA2 levels?
Yeah, so it's because it is a genetic deficiency. We don't really expect the activity to come back. So if the patient has whether it's missense mutation, nonsense, or frame shift type of mutations, the correct gene product isn't produced. So even if you correct inflammatory setting using TNF inhibitors or other treatment, we don't expect the ADA2 level to come back. We measured it in multiple patients that it's always deficient. So that seems to be the case for DADA2 patients. In healthy individuals, however, we do see ADA2 levels can go up and down. I wouldn't say healthy. A healthy individual typically is pretty stable as well. In kids with macrophage activation syndrome, particularly, so it's sort of a different spectrum what we deal with in pediatric rheumatology. They seem to have much higher ADA2 levels when they're sick with MAS. So we've seen them in kids with congenital HLH as well as a systemic juvenile arthritis that have MAS.
So that it could, in a sense, not exactly, but in a sense, be like an acute phase reactant kind of thing.
Correct. So we've found that it's inducible by certain cytokines like interferon gamma. So adding onto that connection between interferon gamma and ADA2 here.
Well, but if someone in here, I'm just, I'm not the person that asked this question, so the follow-up questions are mine, just because I'm interested in this. If someone had a variant, though, that was associated with reduced but not absent activity, you know, let's say they have 3% or something like that residual activity, and then if the cells that are producing ADA2 are exposed to interferon gamma or some cytokine that induces ADA2, could one, under those circumstances, see an increase? And it may be that you haven't looked at that, but just curious.
In theory, the answer is yes. We also had a couple of recent cases where they have 2 mutations, but their activity level is sort of in that low carrier range, but not absent as you expect for most other patients. So I think it is a scenario, but we do need longitudinal samples from these patients to know sort of what the true answer is.
Okay. All right. Well, thank you for that. And let's see, what other questions? Okay. Here's a good question for you, Pui. This is a time-honored question. This kind of question goes back to through the ages. Are there siblings or DADA2 patients with the same mutations in ADA2 but different phenotypes? And if yes, how can you explain this?
So I have a limited cohort in Boston, and so far the family members that have a sort of a more than one child, they all have either the same phenotype or have not yet developed a phenotype. So I think I would sort of direct that to the Mandy and others who have a much bigger cohort to answer this question.
Okay, Mandy, he's picked on you.
Thank you. I'm happy to weigh in. We do have some families where if you've been watching the videos, there's one family over in Israel where the dad said, we were a family of 5 and now we're a family of 4. And it's because there was a very inflammatory brother who passed away from the disease, and the daughter has had much more of a problem with the neutropenia. And then there are other families too, where you've seen one who have multiple strokes, and then there'll be another one who had like trilineage marrow failure. So I haven't gone to look to say, for instance, are they the R169Q that goes across, like in your talk said, all 3 of your subgroups, or what we're dealing with, but it isn't always quite so clear cut.
Right.
Dan, I'll add a little bit to that, just out of knowing all the patients in the globe. There are 2 identical twins in Italy. Obviously, the genotypes are the same. One has had a bone marrow transplant, and one hasn't. So if that doesn't show you how complex that question is, I don't know what does. But the one that has not had a transplant is doing absolutely fine on TNF.
Yeah, well, the reason that I said that it's kind of like a time-honored question is that, certainly for a number of genetic diseases, and certainly ones that we've worked with over the last few years, we can certainly see cases where one sibling, well, like for familial Mediterranean fever, that one sibling will have, very severe attacks and the other will have milder attacks, or, the attacks may be peritoneal attacks for one member of the family and plural attacks for another member of the family, and why is that? And I mean, it's a great question. It really is a great question, and you know, it gets to the whole issue of penetrance and possible modifier genes and environmental effects that may, in some way or another, influence the phenotype that one observes in a particular disorder. And you know, in some cases, if you're dealing with a disease like cystic fibrosis, you can actually have sufficient numbers that for a mutation like the deletion at position 508, that one could have sufficient numbers of individuals to figure out modifier genes. But for a lot of diseases where they're relatively rare, then to have enough people that have one particular mutation that you could figure out the modifier genes for that particular mutation, it gets hard. But certainly it's a important question, and one that certainly families that have the disease, if there are multiple people in the family, they are certainly asking that question of us as their physicians. Okay, so anyway, let's see what other questions we have here. Mandy, I said I'd leave you off the hook, so I'm not going to ask you any more questions. Let's see here. Here's one for Alice Wu. So thank you, Dr. Wu. Fascinating. With interferon signaling up, can we say DADA2 patients are in some ways in a state of chronic viral bone marrow suppression-like situation environment?
Okay, so I guess compared with you guys, I'm not an expert on DADA2 this disease. What I learned from, I don't see patients, but what I learned from the literatures or reports that we do have patients, they have kind of marrow failure manifestations, like they have maybe 1, 2, or tri-lineage, like they have low blood counts. So the reason we think for that is secondary, as the question asked, is secondary to the elevated level of inflammatory cytokines, including TNF-alpha or interferon gamma, because the roles of TNF-alpha and interferon gamma, we have modeled this in mouse, and we show that these two key inflammatory cytokines, they do suppress hematopoiesis. So I think basically the answer to this question is yes. We think the cytopenias we observed in some of the patients are secondary to the increased level of inflammatory cytokines like TNF-alpha or interferon gamma.
Okay, so I'm going to take the interrogator's prerogative and ask you a question that wasn't on the Google Doc, but certainly occurred to me as you were giving your talk, and that has to do with the expression levels of the ribosomal proteins, the components of the ribosome, which, of course, mutations in which have been associated with Diamond-Blackfan anemia. You pointed that out.
Yeah.
Did you happen to look, and I realize that it probably is not the case, that that would just be a matter of luck. If you looked at anyone who actually had Diamond-Blackfan anemia, was diagnosed with Diamond-Blackfan anemia amongst the cohort of individuals that you did the single cell analysis on?
Our group, we didn't do that kind of analysis, but I think it's very lucky that I attended a talk this morning, and their group actually they did some single cell work on patients with DBA, and they actually found that those ribosomal genes are increased in these patients, which we observed that the ribosomal genes are downregulated in DADA2 patients. Currently, I don't have a hypothesis or explanation for that. But for sure is that those ribosomal genes are involved in red cell development and in red cell hematopoiesis. So I think it's basically something worth to do more research.
Yeah, well, I wonder, so the patients with DBA, at least some of them, have actual mutations in the ribosomal gene. So I just wonder whether, it may be that the other ribosomal genes are upregulated, through some sort of a feedback loop or whatever, that, they have a mutation in one of them, but because it's a multi-protein complex, there's something that gets induced, that would, try to compensate for that in the cell. And so they'd have high levels of, I'm just talking here now, but they would have high levels of gene expression of those other genes, to try to make up for it, and that what you're looking at here in the DADA 2 patients is sort of a different process where all of or many of the genes are down, because presumably something is maybe it's stress, as you were saying, intracellular stress that's in some way inducing that.
Hello, I have another question. Do you hear me?
Yes, Ivona, please go ahead.
We heard today about high IL-23 levels in peripheral blood samples of patients with DADA2. And I remember that single-cell RNA sequencing mentioned a high expression of several cytokines, but not IL-23. So how do you explain this discrepancy?
Sorry. So we did two things. We measured plasma cytokine levels in these patients, and in our panel we don't have IL-23. And IL-23, we definitely can check the gene expression level. Usually there will be discrepancy between the mRNA level and protein level. To be honest, I didn't check that yet, but I can definitely check the mRNA expression level of IL-23. It is interesting. Yeah.
This question, just to point again that you should be looking for the expression.
Yeah. Thank you.
All right, so now I have a question for Carson Chen. And this is a tough one here. Is your test cheaper than a standard ELISA?
It's supposed to be cheaper. So typical test strip costs about $10 to $15.
So go ahead.
But it also depends on the regulation process we have to go through, because typically it's not the cost of the test strip. It's also involved in the regulatory process or other preparation needed. Otherwise, if we only consider typical strip, it's typically within the $10, $15 range.
Mm-hmm. Yeah, I suppose that, with any of these kinds of things, calculating the cost, especially early on when you're still in the stages of development, it's hard to know exactly, and there would be some overhead costs associated with the regulatory process, as you say, and other such things. We're now at about 12:38. We're already, I think, 10 minutes over, but I'll just maybe pick out one or two additional questions here, and then we can call it a day. And of course, those questions that are not addressed here can be addressed by email later on, and we will certainly allow that to happen and facilitate that happening. So the last question, I think, will be for Anne and Samantha. And that is a question of, let's see, as you found the prevalence very low in certain populations, is there a possibility or known fact that some genes may silence the other genes somehow or correct the variant to the more common variant? Also, how can we study the effects of the higher frequency variants in certain populations? So this is sort of getting at the question of the differences in frequency in different populations.
Yeah, absolutely. So for the first question of whether we saw an effect of silencing the gene, that's not something that really, when we're doing the variant curation, is something that really bubbles up to the surface. We certainly don't look at variants in a silo, especially in autosomal recessive disease. It's very common that we look at one variant and that causes us to have to look at 3 or 4 other variants in order to kind of come to our final conclusion. But we didn't see any evidence or anything that came up that made us think that certain variants are being silenced in particular populations. When we do this analysis for a wide variety of diseases, really what we actually are thinking of is the way that we ascertain these variants that we're assessing is through either variants that are listed in public databases like ClinVar or through variants located in the literature. And we know that there are innate biases in how those people are ascertained. So certainly the people who are provided genetic testing and the people who are provided answers through genetic testing are, quite often from higher socioeconomic statuses. They are often from, particular regions or particular countries. And so often that is what is biasing our list of known variants that we can then be looking for. So from the genetic counselor's point of view, I feel very strongly that the reason we're seeing certain populations with more variants has to do more with the clinical biases than actually the baked in genetic biases that perhaps things like mechanistically are happening. So that's sort of my point of view on it. Certainly there could be something going on there, but I think we're really at early stages of thinking more about the fact that the initial list that we're looking at has some clinical ascertainment bias. And then can you remind me of your second question one more time, just so I make sure I answer it?
Yeah, well, that was such a good answer to the first question that it made both you and me forget about what was the second question. So how can we study the effects of the higher frequency variants in certain populations?
This is something that came out of our studies as well in other diseases, that initially we thought we were just going to get this list of likely pathogenic and pathogenic variants, would give people the disease prevalence and sort of our collaboration would be over. But what's really coming out is that we're finding that this is going to be a really rich ongoing process where we can work with various groups in a couple different ways. One is we can provide both that list of likely pathogenic and pathogenic variants for them to say, great, let's study these more. There's a lot of evidence to say that they're causing disease. We can look into that phenotypic spectrum. A lot of the questions that all of you brought up that I think are great questions that almost every foundation and group is thinking about, which is what is the phenotypic spectrum, both for the entirety of the disease, but also for specific variants or mutations. But the other collaboration that we can have is this list of VUSs that we put through curation because there was reason to think they were likely pathogenic, but they just don't quite get there. And we really think that that's a high value list and saying, let's do some functional studies and see if any of these fall out or see where we could go. Are these hypomorphic? And that's why they're not making this sort of more Mendelian view of curation kind of get to pathogenic or likely pathogenic. So we're really hoping that we can kind of continue to work with these groups and provide these variants to say, we think that these are rich for this type of study. They can feed that information back to us and then we can update the numbers. And that's really the hope for the online calculator, is that it doesn't necessarily actually have to come back to us, that this will be a free and open resource for people like Dr. Lee, who has this list of variants, or other people who are interested in this. They can continue to put that list back into this calculator and kind of keep honing in closer and closer on what that prevalence number is.
Yeah, and I suppose that it could even be the case that one could go into a database like All of Us or something like that, and for these individuals that have kind of borderline levels, see whether or not they have some sort of subtle phenotypic manifestations that, wouldn't rise to the level of making a diagnosis of DADA2, but on the other hand, maybe there is something there.
Absolutely. I think in NOMAD, we're looking to increase both the diversity of the populations that are put in there. But as you're thinking about, what is a healthy control? What is the definition of healthy? That we're going to have this really cool gray area of people who maybe are able to be eligible as deemed as a control in one study, but very well could be on the outer limits of a spectrum in another disease, And I think we're going to certainly start to capture these people who are homozygous, and what does that mean for specific variants. But certainly in order to be able to do that, we need to grow the size of our population databases and be able to have enough numbers to be able to say, do we see this more or less often than we would suspect in a control population? So we definitely need to grow the size of these types of databases and also the diversity of the databases. But I think we're headed there. And I think that in the next 5 to 10 years, there's going to be some really interesting studies, some interesting conclusions that I think, you know, a lot of diseases are going to be really shocked at what they find. And it's going to bring us into a new era.
Yeah, absolutely. Absolutely. Well, thank you all very, very much. We're at 12:45 now, and I do want to be at least somewhat respectful of people's time. So anyway, I think we'll call it to a close now.